Welcome to Learnings from the ADA, brought to you by Diabetes India. Along with me, chairing the session is Dr. Amit Gupta. And today we have three talks, starting with oral small peptide, achieving more. Dr. Neeta Deshpande will be enumerating on it. And then we have efficacy and safety of Kargisma by Dr. Rucha Mehta, and then next generation therapy for obesity by Dr. Makra. Without wasting any time, thank you for the last 3 days. We've been having wonderful sessions. This is the third day, wonderful sessions and learnings from the ADA. My co-chair, Dr. Rakesh, will join us. Dr. Neeta is a professor of medicine, a certified bariatric physician, does a lot of work in obesity. She's been the chairman of KRSSDI, currently executive committee member of the RSSDI. I am practicing from Belgaum, a good friend of ours. Dr. Neeta, I will not keep on talking about the introduction. Please go ahead and let's listen to you. Thank you.
Yeah, thank you. Thank you so much, Sanjay. Thank you, Amit. And thanks to Diabetes India for organizing this very, very relevant series where you are taking up snapshots from the ADA because a lot of new things and important things happened in the ADA this time. And I'm going to be touching particularly upon something really, really very new. Let me start by sharing my slides. Yes. Is my screen visible?
Yes, Dr. Neeta, visible. Visible and audible, yes.
Right. So I'm going to be speaking about something very important, oral small peptides. We've all heard of GLP-1 receptor agonists. They've taken the world by storm. And we also have one oral GLP-1, but it is a peptide in a pill. I'm going to be talking about small, actually non-peptides, oral small non-peptides achieving more. And I'm going to give you a snapshot of this. So these are the key milestones in the development of GLP-1 therapies, as you can very well see here. The first one, exenatide twice daily, came in 2005, and then in 2010 came liraglutide, which was the first once daily GLP-1 receptor agonist. Cut to 2014, and then we had liraglutide being licensed for use for obesity even without diabetes. And then came 2023, where we had tirzepatide, which is a dual agonist, a twin cretin, and this was approved for obesity. And then in 2024, very, very interestingly, came the first positive CVOT trial with semaglutide in obesity. So these have been the milestones, but we have now gone even further, and that is the most important part that I'm going to be talking about. There are almost 200 classes of GLP-1 related therapies being done today. And as you can see in the slide, you have dual agonists, triple agonists, and in this ADA, there were some posters and there was discussion about quadruple agonists as well. But I am going to be talking today about some drugs that are related to this one on the top right, which is orforglipron, which is one of the prototypes of very small peptides, non-peptides, oral drugs that are in phase 2, phase 3 trials. And I'm going to give you a snapshot of that. So these are non-peptide GLP-1 receptor agonists, and this is the huge pipeline as you can see here. What you see in red down there, the studies have stopped because of some liver toxicity, but these are all the others that are there in preclinical phase 1, phase 2, and phase 3, as you can see here. Now, what are the benefits of non-peptide GLP-1 receptor agonists? For one, they have a higher oral bioavailability. And very, very significantly, there are no food or water restrictions. There's nothing like you have to take it first thing in the morning with only so much of water because there's no technology. It's a non-peptide. So it's much simpler to administer than oral semaglutide. And very, very significantly, the manufacturing process is simple. Now, why is this important? This is important because it makes it very, very accessible globally. because the manufacturing process is simple and there is no requirement to take this on an empty stomach, no 30-minute waiting period. None of those restrictions are there with these non-peptide GLP-1 receptor agonists, and that's very, very significant and important. So I'm going to go first to some molecules which are in phase 2 and phase 3 which are ongoing. So one of them is called the HRS7535, which is an oral non-peptide. Phase 1 data showed favorable PK studies for once daily dosing in type 2 diabetes. Phase 2 is ongoing. There's not much data available. And phase 3 is happening in type 2. They're called the Outstand 1 and 2 studies, and obesity. And these are not yet started. This drug, HRS7535, mainly the trials are being conducted in China. But some of these, what I'm going to show you, came out as posters in this time's ADA, this year's ADA. And this is the same HRS7535. And you can see that the change in weight from baseline to week 16, because it's phase 2, they actually go very aggressive on increasing the doses because they want to see efficacy in a shorter period of time. That's what happens in phase 2. So these were patients with obesity and type 2 diabetes for 16 weeks with 235 patients. And you can see a decent 7% reduction in weight, which is very good considering that this is a oral non-peptide. There's a second one where studies are ongoing in both the US and China, and that's called the CX11. This is also an oral non-peptide GLP-1 RA. It is also once daily and it has a shorter half-life. And phase 2 studies are going on in China for both obesity and overweight. Phase 3 has started in November 2024 and they expect the results somewhere in 2026. And these were individuals with obesity with a BMI of more than 28 or lesser, but with comorbidities. And the dosages 160, 120 were pitted against the placebo, and the study is still ongoing. So this is the CX11 in phase 3. Now, what happens to the liver function? We're very interested in this because some of the GLP-1 RA, as I told you right in the beginning, had liver toxicity. But what they found is that both the ALT and AST actually improved. The liver function actually improved in phase 2 trials with this particular drug, which is very, very encouraging. Then this is another small oral non-peptide, which is allanglipron. So allanglipron, you have phase 2A data overview. And this was actually presented in 2024. And it is again once daily. Phase 2B studies are going on. It's called Access Trials. So it's a group of trials called Access Trials. It has all been fully enrolled as of February 2025. So you can then expect the results a little later on. So you see actually that there's a lot happening. Imagine the number of drugs that are there. They're huge in number. Small oral non-peptides themselves are about 50 in number, which are being tested. And this is just some of the data and some of the trials that I've been showing you. Now coming to the one that has actually shown results, and that is orforglipron. It was done in diabetes. The phase 2 was done in diabetes, and it is a first-in-class oral non-peptide GLP-1 RA, once daily with no food or water restrictions, as I mentioned before. They have two types of trials. The ones going on in obesity are called the ATTAIN series of trials, and those that are there in type 2 diabetes, and one which is published recently is the ACHIEVE trials. And they expect approval in 2026, FDA approval in 2026. And this was data, efficacy, and safety in a type 2 diabetes. So this was the phase 2. So as you can see here, even in this phase 2 diabetes study data, you can see that there is significant weight reduction. And this is 26-week study. As I said, the escalation of doses is pretty fast in a phase 2 study. And you can see that every time point, you can see that the weight is still reducing. You're not seeing any stagnation even at 26 weeks. The graph is going right down. And you can see here that there is, for a comparator, there is dulaglutide and then there is placebo. And you can see good 9 to 10% weight loss. Then, since this was in type 2 diabetes, obviously A1C was one of the endpoints. And you can see that the main change in A1C was pretty impressive at 2.1%, 2%, 1.9%. That is very, very significant. And this is phase 2 data for type 2 diabetes for orforglipron. Then you have AZD5004. This is phase 1. There's limited data. Phase 2B is also ongoing. So again, these are just different names for the same type of drugs. We don't know which ones are the ones that are going to emerge winners in terms of weight loss as well as A1C, but these are all the drugs that are in the pipeline. Now let me focus on orforglipron, which is a small molecule. The advantages I have already told you: higher oral bioavailability, no food water restrictions, simple administration, manufacturing is easy. So Achieve 1 trial is completed and I'm going to show you the data. Achieve 2 is versus, it is compared with dapagliflozin and it is ongoing. Achieve 3 is compared to oral semaglutide, that is also ongoing. This is going to be an interesting one because this is the first oral non-peptide and oral semaglutide is the only oral peptide, GLP-1 RA. So they are going to be compared. And for weight management, the ATTAIN trial is ongoing. As far as the safety considerations are concerned, I'm going to go into that a little more in detail in the following slides. At least they had no adverse liver signals. Now, why is that important? I told you that danuglipron had to be discontinued because of this particular liver toxicity concern. So this was the Achieve 1 trial design. This is the completed one. There were 559 patients with type 2 diabetes treated with diet and exercise only or off medications for at least 3 months, standard protocol. So they had arms for orforglipron in 3 doses, 3, 12, and 36 milligrams or placebo. And they studied it for a good 40 weeks. The baseline characteristics were that type 2 diabetes duration, the mean was 4.4 years, mean A1C was 8%, mean body weight was 90.2 kgs, 48% of these were women, and 38.3 had glucose lowering agents in the past. Primary endpoint, because the Achieve trials are in type 2 diabetes, primary endpoint was a change in A1C at week 40, and the secondary endpoint was body weight at week 40. So the patients who are here were early type 2 diabetes. That is something that you should keep in mind. And these were the results. On the left side, you have HbA1c reductions, and on the right side, you have the weight loss reductions. So HbA1c, you can see that there were dose-dependent reductions versus placebo. So I told you you had 3, 12, and 36 milligrams. So you had 1.2, 1.4, and 1.48%. It's almost 1.5. So as the dose was increased, you had better A1C reduction. How many people achieved what kind of targets? So about majority, 2/3 of the patients almost achieved an A1C of less than 7%. So it is highly efficacious. If 2/3 of the population studied could achieve less than 7%, it is a very good drug. 57 to 62% reached an A1C less than 6.5, and a quarter of them achieved an A1C of less than 5.7, almost going all the way back to the non-diabetic status. So that is very, very interesting. What about the weight loss? If you look at the weight loss, there were dose-dependent weight reductions again versus placebo. So 3 milligrams, 12 milligrams, 36 milligrams, progressively, you had better percentages of weight loss, the highest being 7.6. And what about the percentages? So more than 50% of them, 43 to 61, lost more than 5% body weight, which is good. 15 to 30% of them lost more than 10%, and 4 to 10% of patients lost more than 15% body weight. And there were also improvements seen in lipids, waist circumference, and systolic blood pressure. So the Achieve 1 trials are seminal because this is the first phase 3 trial with an oral non-peptide GLP-1 receptor agonist. As far as the safety was concerned, what did they see? They saw that most common adverse events were again gastrointestinal, mild to moderate, and generally decreased over time, like with all the others. No adverse effects on the liver, which was again very important. Other safety findings: no severe hypoglycemia, no pancreatitis, and discontinuation rates were the same as what we have seen before with the other GLP-1s. Now, there are some known risks and unknown risks based on some known information. It's a new class of drugs, so we got to be careful. So, there is known information, and these are slides that have been taken directly. I have to acknowledge from the presentations that I have attended. So, gastrointestinal defects, effects, we know they are dose dependent, we know they are GI tract related. And there's a small increase in pancreatitis markers. That's something we know. Hypoglycemia is a question mark because it depends on what you pair it with. Heart rate increase, we don't really know. But what is the unknown information? The unknown information is about the off-target effects, about the long-term safety profile. Of course, more trials are going on in phase 2 and phase 3. Liver function, whatever has been studied so far, has been encouraging, but we still have to be careful. Cardiac and renal effects, more data is needed. Immunogenicity, again, you need more data. For drug interactions, again, more data is needed. So they're in the phase 2 and phase 3, encouraging results both for A1C and for weight. However, what we need to understand is that there is a lot of unknown information out there, as it is with any new class of drugs. So it remains to be seen, and we need to watch out. So, what's the summary of all of this? Is the promise of oral non-peptide GLP-1 RAs real? Yes, the promise is real. It does look very promising. There are caveats. We need to be careful, but it is well worth the wait to watch out for what these drugs can do. And they represent a breakthrough in oral GLP-1 receptor therapy. They offer higher bioavailability, no food water restrictions, and very simplified dosing. They avoid complex injection or strict administration protocols, and hence you may expect better patient adherence. Also, it's likely to be cheaper because the manufacturing process is easier. There is scalability, especially in resource limited settings. Early trials, as I have shown you now, show clinically meaningful reductions in A1C and body weight. And safety profiles are very encouraging with minimal GI issues and no major hepatic signals. And as development advances, non-peptide agents may transform, I said may transform, diabetes and obesity care by making these effective therapies more accessible, acceptable, and sustainable. So I have stopped with 3 minutes to spare.
Thank you. Thank
Yeah,
you,
Sanjay. So
Neeta.
thank you all, whoever's
Welcome,
listening. Thank you for
Dr.
a patient.
Rucha and Dr. Makkar. I will a couple of minutes for question. Very interesting, but they're all tongue twisters. Very difficult to
Very
pronounce.
difficult. They're tongue
Well,
twisters. I
they're tongue
agree.
twister. I don't mind them being a tongue twister as long
Yeah.
as they're going to be
It took me a
oral.
while to say or floor, and then I
Yeah,
still make a
we'll
mistake.
get used to it. It was very difficult to say even Excidin 4 at a point in 2003, and then
Yeah.
look at where we reached in 2005, and all these molecules. Looks an exciting era for making peptides available orally first. That was
Yes.
one of the biggest breakthrough.
They're actually non-peptides, but they're
They're not.
GLP-1 receptor
The
agonists.
peptide first, gastrointestinally, making available orally was one breakthrough. And
Yes.
we have non-peptides probably performing better than peptides. It's a very, very interesting story. And orally drugs. I was thinking they're not going to manufacture any more oral drugs. Excited to see this data. No, I was been following up this drug for long. I hope
Yeah.
I open this chat. If there are any questions by the audience, if there's anything in the chat box, interesting times and more to come. I think we need to follow it up and see what's going
I
to
think we
happen.
have questions at the end, Dr. Sanjay. We have put
No,
discussion
no.
at
Yeah,
Yeah,
at the end,
I need to
Dr.
leave. That's the
Nita
reason I
requested that she
requested.
had to go, so I
Okay.
just got it. In the end, yes, we will definitely have it. So if there's any questions, I don't think they are. Just
Any questions come up, I'm sure Dr. Makkar and Rucha both going to
I
answer.
will answer. I think both of you were there. Thank you, Dr. Nita, for throwing light on oral
Yeah.
small peptide and non-peptides and what we can achieve now.
Thank you. Thank you.
Thank
Thank
you
you so
very
much.
much.
Bye-bye.
Once again, good evening and welcome to Leading Learnings from ADA. We have uh, Dr. Rucha Mehta from Ahmedabad, who's an endocrinologist, a bariatric physician, who's going to speak on efficacy and safety of Cargisima. She's trained. She's a DM endocrinologist trained in America for some time. She works and is very active in obesity management over the years. Over to you, Dr. Richa, for your
So
deliberation.
just a small correction, though I keep sending it, RX doesn't make the correction. It's MD endocrinology in the US and not DM.
Yeah, I understand.
Yeah.
I know you were trained, that's why I didn't want to
Yeah.
tell
So,
about it. That's
yeah.
okay.
Okay. If I can
If,
have if they can allow me to start sharing, then I
yeah,
can.
yeah. Please allow Dr. Richa to share a screen.
Okay, good. All right. And great. Thank you for this great opportunity. And I think this is very important and key discussion topic. As I said, half of ADA this time was more on obesity. And I've always been saying for the last several years, I think all of us, Dr. Makkar, myself, Neeta, that obesity is the new diabetes. So in the next several minutes, I'll talk about CagriSema and how can we potentially leverage all these therapies, and is there a role in obesity and more importantly in cardiometabolic regulation? Because just like we think of obesity as a disease, we need to understand why. And therefore, we'll talk about first, of course, what is this molecule and what is the effect on energy intake and expenditure. So amylin is this molecule which is sort of like the second beta cell hormone, and it's co-located and co-secreted along with insulin from the pancreas. Now, on its own, it has a very short half-life, of course, of just about 15 to 20 minutes. It also works mainly on the area postrema in the brain. So, of course, just like your GLP-1 molecule, it has effects on gastric emptying, but more importantly, its effect seems to be centrally mediated also by acting on the area postrema in the brain. Let's see why it's not advancing. Yeah. Now, the role of amylin is very important in the regulation of appetite as well as glucose. It reduces pancreatic glucagon secretion and thereby helps in glucose management and endogenous glucose production. It increases satiety level and decreases the rate of gastric emptying. Now, interestingly, it also works at the level of leptin and improves leptin sensitivity. And we know that we cannot succeed in the battle against obesity unless we work not just on insulin resistance, but also on leptin resistance. It also counteracts a decrease in energy associated expenditure associated with weight loss. Because this is very important feature in the maintenance of weight loss. Because we know as patients lose weight, their metabolism goes down. And very often when molecules are stopped or diets are stopped, they have a rebound effect and regain weight. Hence, amylin has multifactorial effects. Appetite regulation, both on the homeostatic and hedonic feeding mechanisms. What this means is, when we eat food when we are not hungry, for example, as a reward mechanism, as a stress mechanism, when we go to watch a movie, and amylin sort of seems to negate this effect. It also partially restores the leptin responsiveness. Now, at the level of the pancreas, as we've already spoken, it helps in glucose regulation by working on the glucagon and the insulin pathway. At the level of the GI tract, gastric acid secretion is reduced and gastric emptying is slowed down. Now, importantly, that it also seems to have effects at the kidney by reducing systemic oxidative stress, and maybe at the level of bone by helping in bone, improving bone formation and reducing bone resorption. So these are some interesting molecules that we have in the pipeline. So CagriSema, now what is this new molecule? So CagriSema is a dual molecule that has an amylin analog and a GLP-1 analog. And the semaglutide as well as the cagrilintide both are once weekly. The cagrilintide in here has an 84% sequence identity to native human amylin. And the amino acid substitution, as you can see, it removes the fibrillating properties of human amylin and now makes the half-life very long, almost up to 180 hours. Similarly, the semaglutide, as you already know, has a 94% identity to human GLP-1, and the half-life is approximately 155 to 185, which is about a week, so to say. So therefore, combining these two molecules is in clinical development for obesity and type 2 diabetes. So how does CagriSema help in weight loss? It reduces energy intake and helps to improve energy expenditure. This was obviously the idea, how it developed. First, it was tried out in dio rats. And what we found is that the body weight goes down, especially the fat mass seems to go down, and the lean mass seems to remain preserved. I don't know, I'm having a trouble advancing the slides. Here we go. Okay. All right. Yeah. So what are the effects of CagriSema? And now let's look at some data from the REDEFINE trials. So REDEFINE is a phase 3 trial evaluating CagriSema in people with obesity with normal HbA1c or non-diabetic range. As you can see, male and female more than 80 years of age, BMI more than 30 kilogram per meter square, or BMI more than 27 kilogram per meter square, plus or one or more comorbidities such as blood pressure, fatty liver, and they were excluded if they had a history of type 2 diabetes or type 1 diabetes or HbA1c more than 6.5. All of them were given the similar lifestyle intervention, and about 3,400 patients were randomized to receive either CagriSema, and you can see there is a dose titration in the small fine print over here from 0.25 to 0.5 to 1 to 1.7 to finally the 2.4 milligram dose. And the dose escalation is in about 16 weeks. Similarly, for semaglutide up to 2.5 and cagrilintide for 2.4 milligrams. And then they are followed up. The treatment is maintained for about 52 weeks. And then in the next follow-up of about 7 weeks, analysis is carried out. 250 participants also underwent DEXA scan. And the primary endpoints were to look at relative change in body weight versus placebo from baseline to 68 weeks, and also the number of participants who achieved more than 5% body weight reduction from baseline to 68 weeks. We will also look at the number of adverse events and serious adverse events related to the treatment. So let's see what happens. Very nicely, the mean body weight. So this is the baseline that they had a mean body weight of about 106 kilograms, mean BMI 37, mean age was 47 years. 67% were females. Mean HbA1c was 5.5%, and you can see the race distribution. Now, dose escalation allowed individualized treatments also based on responses, and the protocol did allow for some flexibility in dose adjustments. And what you see is that investigators were allowed to reduce the dose or delay escalation if the patient was not able to tolerate the current dose, or if they reached a BMI in the lower normal range with a health concern. So what you find over here, that CagriSema achieved a mean weight reduction of about 22.7% from baseline. And you can see with cagrilintide alone, that was 11.8%. With semaglutide, about 16%, but the combination gives you this whooping weight loss of about 22.7%. And greater proportions of participants reach the threshold when we use CagriSema, so more than 2 times versus the monotherapy. And this is important to keep in mind. Now, importantly also, since there's always this concern for muscle loss, the CagriSema combination improved body composition with majority of improvement driven by reduction in total body fat mass, and there was not much loss in the soft tissue or lean mass. Okay, so you can see over here. All right. Now let's move on to REDEFINE 2. So REDEFINE 2 attempted to see if we could get the same results in patients who have obesity along with type 2 diabetes. So herein we take similarly male or female more than 18 years of age with a BMI more than or equal to 27 kilogram meter square, diagnosed with type 2 diabetes and HbA1c 7 to 10%, who are on diet and exercise alone or 1 to 3 oral anti-diabetic drugs. So about 1,200 patients are randomized to CagriSema versus placebo. There's a dose escalation period and then a maintenance period and a follow-up period. CGM was also applied in about 200 patients at baseline, week 24, and before the end of treatment. The primary endpoints is to look at change in body weight and also more than 5% weight reduction. The secondary endpoints are achievement of more than 20% weight reduction at week 20, BMI category improvement, and change in HbA1c. And lastly, we will look at the hypoglycemic episodes as well as adverse events. Sorry, I'm just trying to. Okay, here we go. So at baseline, we had about an equal distribution of male and female, close to about 50%. Mean age is 56 years, mean BMI 36, and also mean HbA1c 8%, and diabetes duration of about 8.5 years. About 31.5% were already on SGLT2 inhibitors. So CagriSema achieved a 15.7% weight loss after 68 weeks in people with type 2 diabetes and obesity. And this is, as you can see, versus placebo. Sorry, I don't know. The slides are taking a little bit too advanced. Okay. Majority of participants on the CagriSema achieved more than a 10% weight loss with CagriSema. As you can see, almost 90% with more than 5%. 74% had a weight loss of more than 10%, and almost a one third, 29.22% patients had more than 20% weight loss also. So the effects of CagriSema, not just on weight, but on glucose regulation, shows that there is a nice drop in fasting blood glucose at week 68, and there is also a change in fasting serum insulin at week 68, improved insulin sensitivity. Sorry, I'm trying to advance. Yeah. So as you can see, the improvement in HbA1c from baseline is about 2%. And this happens very quickly, almost as quickly as 3 to 4 months. And that effect is sustained. Now, as I mentioned, about 200 participants were applied with continuous glucose monitoring. And you can see over here that CagriSema reduces the glycemic variability and improves the daytime glucose stability. So time in range went from almost 43% to 87% at the end of week 20 versus placebo, wherein it only goes up from 40% to 50%. Now let's move on to adverse events. As we know very well that we don't expect a severe incidence of hypoglycemia despite the weight and glucose lowering with CagriSema. So level 2, as you can see over here, that clinically significant or severe hypoglycemia were negligible, about just 0.2% with CagriSema. And then looking at other cardiometabolic parameters, that besides weight loss, besides diabetes improvement, there's an improvement in the systolic and diastolic blood pressure with CagriSema in REDEFINE 1. And this was almost up to the tune of 10.9 millimeters of mercury. There's an improvement in the cholesterol levels as well, with reduction in total and LDL cholesterol, improvement in the HDL cholesterol, as well as improvement in triglycerides seen with the CagriSema molecule. So the safety profile, what we know, here is adverse events by preferred term. So the most commonly as anticipated was nausea, constipation, vomiting and diarrhea. Fatigue, this seems to be a common scenario we see with some of these molecules. And more importantly, patients complain of asthenia. So this is something that was found, and we have to watch out for this and try to minimize it for our patients. Now, nausea and adverse events seem to get better over time for sure. Now let's move on, and just for the last 1 minute, I will talk about a look to the future. So amycretin is a molecule that is now sort of in the pipeline, and it is the first unimolecular. So it's a single molecule that will work at the level of the GLP-1 receptor and the amylin receptor agonist, with both subcutaneous and oral formulations currently in clinical development for weight management and type 2 diabetes treatment. Okay, so as you can see over here, that amycretin has important effects on weight loss as well as improvement in HbA1c. So this is the estimated mean change in body weight from baseline by end of treatment. Okay, so Novo Nordisk is the company that is making this right now, and they have certain other molecules that were shown during the course of the ADA. And we have these ongoing trials that we expect from them: REDEFINE for obesity, REIMAGINE for type 2 diabetes, RENEW for cagrilintide alone, and AMAZE for amycretin. So stay tuned, my friends. We have lots of things happening in the field of obesity, and hopefully very soon, just like diabetes, we'll have multiple molecules to pick from. So let me stop right there. And thank you very much for your attention. And I hope I'm in time. And I'll hand it back to Dr. Sanjay Reddy. And
Thank you,
hang
Dr.
around.
Rucha. It's interesting to note the results of
Yeah.
CagriSema and the way all the pathways have been explored. Now, it goes back and always try to remember the satiety pathway from Harrison, which has all and still go back to that diagram and the picture, and the hypothalamus there, and
Yeah.
every types of molecules.
Sanjay,
Can't
signals
hear
are
you,
dropping.
Sanjay. Sanjay can't hear you.
Yeah. So for lectin and we knew that leptin resistance was one of the main reasons why we were able to make leptin as one of the therapeutic possibilities for obesity. Now we have something probably pushing leptin sensitivity to a better level with Kargisema and all of this. Interesting times, more and more understandings to come. Thank you very much for your wonderful talk, and then we'll go back for questions in the end.
No
Now,
worries. Yeah, I'll be around.
Dr. Yeah, thank you very much. And now we have Dr. Makkar. Good evening, sir. Welcome.
Good evening, Dr. Sanjay. Good evening,
It's a
Dr.
long time.
Lucha.
Yeah, but Dr. Makkar is the past president of RSSDI, honorary secretary of the Obesity Society of India, ex-chairman,
Sanjay, you
RSSDI
can skip
chapter.
this.
We'll not talk about how many orations he's given. Dr. Makkar is a great friend of mine. And over to you, sir. And works a lot in obesity, where even people who were at that point of time were not looking at obesity as something, as a therapy, would have some therapeutic potential. Over to you, sir. And you're seeing all of this come
Just to
before.
add one more thing, Dr. Makkad is organizing chair for the meeting of 2026 Diabetes India along with Dr. Rakesh Sai at HICC Hyderabad. So don't forget from 12th to 15th of Feb. And over to Dr. Makkar. I'm sorry I'm not opening my video. Thank you, Dr.
Sanjay,
Makkar Sahab. Yesterday I
you
was
have
also waiting
forgotten
for
the
you.
AOCO.
Yesterday also we were waiting for you because you were supposed to chair the session, but we are now looking for your deliberation.
Okay, I think then there was some miscommunication at my end because I was keeping that chair on 20th. There is a meeting, invite you had sent me, not for yesterday. Anyways, so good evening, everyone. Am I audible?
Yes, sir, you're audible. You're audible and visible. Please go ahead.
Okay, so I am going to share my screen. Can you see my screen now?
Yes, sir, it is visible.
Good. So first of all, I must thank Dr. Sanjay, Dr. Bansi, and team for giving me this opportunity to speak on the ADA snapshots. And my topic is next generation obesity therapies. No financial disclosures for this presentation. Now, important thing is, the wonderful thing is that previous speakers have done my job more than 75%, and they have made my job so easy that I can actually finish this presentation in 5 to 7 minutes also. But I'll take 10 to 15 minutes and try to give you an overview of what is in store. So we have always been looking at 5 to 10% weight loss with the anti-obesity medication. So first thing that has changed is that now we are no more looking at 5 to 10% weight loss. We are looking at more than 15% weight loss, which can give us not only reduction in CVD, NASH, but can help us in modifying diabetes, giving remission of diabetes, reducing cardiac mortality, and reducing the heart failure with preserved ejection fraction. This was because earlier drugs would give us weight reduction of in the range of about 8 to 12% alone when they were used or in combination with lifestyle interventions. But with the newer drugs, the scenario has changed, and we are seeing more and more drugs which are, which have the potential to give us weight reduction going to the range of 30%, which is offered by bariatric surgery. So we are moving, in a direction where maybe in near future we'll be using more of anti-obesity medication, and bariatric surgery will be reserved for very select people. Now, we have two major drugs which have been approved for management of obesity in India. One is the injectable semaglutide, and the name is Wegovy, and other one is tirzepatide, which is available as Mounjaro in India. All this happened because once we started understanding the bariatric surgery, we started learning that this is an intervention which increased the postprandial levels of multiple enteropancreatic hormones. And this led to the notion that combining these hormones would lead to a good therapy for management of obesity. And number of enteropancreatic hormones with diverse metabolic actions are currently under investigation, which will include majorly GLP-1RA and GIP, but We have GIP agonists as well as antagonists. We have glucagon, amylin, peptide, YY, and so on, and a combination of these molecules. And mostly once they are being combined, they are combined with the GLP-1 RAs. The aim is to enhance or complement the effect of GLP-1 agonism on weight and metabolism. There are smart molecules which have the capacity to recognize more than one receptor. They have balance effect or selective bias for one receptor. And now we are looking for tri and tetra agonists or a combination of agonist or antagonist. And we are combining not only the molecule, we are combining GLP-1 RA with the monoclonal antibodies. We are looking at combination of GLP-1 RAs with pyruvate kinase activators. And we are also looking at some genetic interventions, which are very, very interesting. Now, GLP is important because we know that liraglutide was the prototype which was shown to reduce weight by acting centrally as well as peripherally. The central, the brain, it acts both in, arcuate nucleus as well as the hindbrain, stimulating the GLP-1 receptor, thereby increasing the activity of pro-opiomelanocortin and stimulation of melanocortin 4 receptor, ultimately leading to suppression of appetite. At the same time, it reduces the gastric emptying. Now, liraglutide was a weak agent. Semaglutide has, much more potent impact as far as the energy intake is concerned. It reduces the energy intake by almost 30%, while liraglutide reduced only about 16%. And we now have, a number of step studies which have been performed to show that semaglutide injectable is not only effective but safe also in people with obesity. So one of the new molecules that we are using is semaglutide injectable, and it has been studied very well in step 1 to step 4 trials, but other trials also, and all these trials have shown that you can achieve a weight loss on an average about 17% when you are giving injectable semaglutide over a period of 1 year. Not only that, majority of patients achieve weight loss of more than 5%, 70% achieve more than 10%, almost half achieve more than 15%, and a third achieve more than 20% weight loss. Now, this also showed that people who had diabetes and lost more than 10% weight, their A1C also came down in the range of 2.2%, and the starting A1C was only 8%. So, significant number of people achieved remission of diabetes. In addition, they have benefits beyond, weight management. They have reduction in CV risk factors. Blood pressure comes down by 6/3. CRP levels come down. There is, better quality of life and better patient-reported outcomes. We have now 2 years follow-up data. Step 5 trial showed again that we can sustain, even weight reduction of about 17% at the end of 2 years, and more than 20% lose. More than 20% weight loss is seen in a third of patients. So, semaglutide, another important thing is it has been studied in one of the largest CV outcome trials involving 17,600 plus patients from 14 countries, and showed that it gives you a statistically significant 20% reduction in 3-point MACE, which led to its approval for use in patients who have overweight and obesity and chronic artery disease without diabetes, to achieve or to reduce the cardiovascular mortality, myocardial infarction, and stroke. Not only that, there is 19% reduction in all-cause mortality, there is 22% reduction in developing kidney disease, and 3/4 reduction in the risk of developing diabetes. We have 4 years follow-up from select trials showing sustained weight loss at the end of 4 years in people who were involved in STEP trial. No major adverse cardiovascular events, mostly the GI side effects, which are transient. And now second molecule that we are using is tirzepatide. It's a dual GIP GLP-1 receptor agonist, which has single molecule and possesses 2 pharmaceutical targets. It combines synergy between 2 molecules. GLP-1 leads to increased satiety, but increases nausea, while GIP reduces nausea. It also has significant impact in the adipose tissue metabolism, leading to increased insulin sensitivity, increased lipid buffering capacity. That means there is more fat storage in the subcutaneous tissue while it is being mobilized from the ectopic sites. It also reduces inflammation in the adipose tissue, improves insulin sensitivity, reduces ectopic lipid metabolism, which is again very significant. The initial clinical trials showed that we can get not only 2.4% A1C reduction in people with diabetes, there was almost 11% reduction in weight. And this has been further studied in SURPASS trials for diabetes, where again it showed significant weight loss going in the range of uh, 12 to 13%. And this led to development of SURMOUNT program, which are the studies in people with obesity and overweight without diabetes, except SURMOUNT 2, which recruited people with type 2 diabetes also. SURMOUNT 1 data showed very clearly that it gives you a significant weight loss of 22.5% at the end of 1 year, with 90% people achieving 15% weight loss, 5% weight loss, sorry, more than 80% achieving more than 10%, and almost a third achieving more than 25% weight loss. And this led to SURMOUNT 3 trial, again showing, similar impact on weight reduction, with 95% achieving 5% weight loss, 75% achieving 15% weight loss, and a third achieving more than 30 third of weight loss, 25% weight loss. I don't think I'll need to go through Caglintide and CagriSema studies because they have already been studied, discussed by Dr. Neeta, and Dr. Rucha also made reference. It is being studied in redefined program, and this combination appears to be very promising in reducing the MASH, obstructive sleep apnea, heart disease, as well as kidney disease. Then we are also having oral semaglutide 50 milligram, which has been studied in OSIS and one more trial, where it has shown that we can achieve a weight reduction similar to injectable semaglutide with higher dose of oral semaglutide. Oral amycretin, you just listened to, Dr. Rucha about the oral amycretin. Then we have retatrutide, which has come into phase 3 trial now. This phase 2 data was presented last year ADA meeting, in fact 2023 ADA meeting, where it was shown to be very effective and very promising molecule. This was a once weekly injectable triple hormone agonist, which has agonist function for GIP, GLP-1, and glucagon receptors. And this study looked at the efficacy, tolerability, and also the efficacy of various doses in management of obesity. And the doses ranging from 1 to 12 milligrams were studied in this study population. The interesting thing is, only at 24 weeks, you could achieve a weight loss of 18% with the dose of 12 milligrams. And at the end of 48 weeks, people achieved weight loss going to more than 25%. So at the end of 4 weeks, the average weight reduction was 26 kilos, which was close to 30%. Everybody reduced weight of more than 5%, 90% achieved more than 10%, 80% achieved more than 15%, 70% achieved more than 20%, half achieved more than 25%, and quarter achieved more than 30% weight loss. There are a number of therapies which are looking at the GIP, GLP-1, amylin, peptide YY, and their combinations, and they are looking at the advantages and combining, synergies between different molecules. Like GLP-1 reduces appetite and food intake, but GIP reduces nausea, while the GLP is increasing nausea. GLP-1 is, giving you cardio protection and heart protection, while GIP also giving you bone resorption. Then amylin has decrease in food intake, decrease in appetite, decreases osteoclastic activity, and improves bone health. Glucagon also increases nausea but decreases appetite, improves insulin secretion, and increases the energy expenditure in adipose tissue, leading to mobilization of fat. Similarly, peptide YY has its own effects. And most of the molecules that are in pipeline are using the GLP-1 backbone, and they have combination with amylin agonist, which is CagriSema, we just discussed, GLP and GIP, which is tirzepatide, and other molecules also in pipeline. Then there is GLP-1 and GIP glucagon combination. There is a triple agonist retatrutide we just discussed. There is another molecule in pipeline. There is GLP-1 glucagon agonist. There are GLP-1 peptide YY agonists. So this is the whole list of molecules that are in pipeline. And there are number of molecules which are giving you anywhere between 15 to 25% weight loss, which are in pipeline. There are a number of molecules which give you more than 10% weight loss or 15% weight loss. And there are significant number of molecules which are giving you A1C going in the range of 2%, leading to remission of diabetes. Survodutide is a combination of glucagon receptor agonist and GLP-1 dual agonist. Important thing is it has been shown to have very beneficial effects in liver, leading to increased fatty oxidation, glycogenesis, and glycogenolysis and lipolysis in liver, thereby improving the MASLD. And studies have shown that people who were treated with the survodutide lost almost 19% weight. In addition, there was significant reduction in the MASLD without any worsening of fibrosis. And now this is being studied in multiple synchronized trials for people with obesity and leverage program for management of MASH or MASLD. Bastutide is again a combination molecule, which is Chinese molecule shown to have similar effect, as other combinations. Then we have bimagrumab, which is an interesting molecule. It is a myostatin activin inhibitor. This basically, when we are inducing weight loss, if you look at with the semaglutide, there is almost a third reduction in the lean mass also, and two-thirds is going from fat. With tirzepatide also, a quarter of weight loss is going from lean mass and the rest is going from fat. So we want to preserve lean mass. Bimagrumab is a monoclonal antibody that stimulates skeletal muscle growth by blocking the activin 2 receptor. And because of this, there is a significant improvement in muscle mass. So BELIEVE study is a multinational double-blind placebo-controlled study looking at combination of bimagrumab and semaglutide, and it showed that people who were treated with bimagrumab not only lost weight but also preserved muscle mass. There was significant improvement in muscle mass while there was significant reduction in fat mass. Now we have pyruvate kinase activators. We know it regulates insulin secretion, and it's a small molecules which amplify insulin secretion from islet cells. In addition, they also improve the GLP-1 secretion, and studies have shown that if you are using the GLP-1 with pyruvate kinase activators, they lead to increase in weight loss or increase impact on the insulin secretion. They cut down nutrient intake, they improve insulin, they improve satiety, and if you look at the combination, there is significantly higher weight loss when you are using either of them. Not only that, if you look at the lean mass, if you look at the combination with the semaglutide, again you have significantly higher weight loss coming from combination of molecule. In addition, they preserve lean mass or they increase lean mass. So there is fat mass loss while there is increase in lean mass. And there are other nutrient-stimulated hormone targets which can be, combined or impacted with the pyruvate kinase inhibitors. So once daily small molecule pyruvate kinase activators integrate metabolism into nutrient-stimulated hormone signaling as a potential novel approach to improve weight loss without losing muscle mass. Then we are looking at genes, genetic interventions. There are various ways why the gene modifiers act by silencing, splicing, or RNA editing. There is a gene called inhib gene, which has been, identified, and small messenger RNAs are one single injection of small messenger RNA with inhib gene can reduce the weight significantly and can be combined with the injectable GLP-1s. Then we have unimolecular tetraagonists in pipeline, which are targeting GLP-1, GIP, amylin, calcitonin receptors. Basic idea is you preserve muscle and improve muscle mass. This was another study which was presented at ADA, once monthly merid part ceftazidime or marditide. So was a phase 2 trial, again showing significant weight loss. The important thing is this is to be used only once a month. And then we have quintuple agonists. So we have peptide molecules on which we are attaching a nuclear receptor modifier or nuclear hormone like a steroid. And the peptide molecule it internalizes along with the nuclear hormone, where it separates and goes to nucleus and changes in the genetic expression. So there are tripeptides with steroid conjugate, and the initial data shows that they can give you weight loss going in the range of 40%, which is anywhere better than even bariatric surgery. Not only that, suppose you have once a month molecule and you have a once a year version of Wegovy. So it will act as a vaccine. You take a shot once a year, and Novo is already working on that. So we are on the verge of takeoff into a fantastic journey in obesity management. But where we will end up, we don't know. There is caution to be observed. We recently had data that danuglipron was, removed from development because of the liver toxicity. We are seeing reports coming on the age-related macular degeneration, and WHO has given warning about anion. So we have to be vigilant, but we are looking at a very promising future. With that, I conclude, and I would also, like you to block 2 sets of dates. Bansi has already given you third set of dates for Diabetes India. So 30th, 31st August, we are hosting ACCD in Delhi, and December, this date has changed. 19 to 21st December, we are hosting AOCO also in Delhi. Thank you so much. I'll be happy to take any questions if there are.
Thank you, sir. Very interesting to note. And thank you for your talk from peptides to. So ultimately, we know that it's not one peptide which is going to work. Multiple of peptides are going to do or going to take off into a different tangency over a period of time. And that's interesting to note. And also, preserving lean mass is also becoming another thing. So, Dr. Rucha and Dr. Makkar, let me start with the first question. We see all of these reports, and majority of these molecules work somewhere on the appetite stimulation and suppressant pathway. Do you think we're going to see in real world when we use them more differently in terms of they become more acceptable and more usage? Do we see something on the terms of a behavioral change which is going to happen?
Fortunately or unfortunately, I would like Rucha also to comment on this. The people are thinking that these are magic bullets, and you use them and you will lose weight, and then weight will stay there. First thing, people are not, understanding that these are medications which are to be used like any chronic disease medication. So first thing is people are not recognizing obesity as a chronic, relapsing, serious disease which needs to be treated lifelong, and you may need to continue these molecules lifelong. Second thing is safety data is now available with semaglutide. We are expecting the safety data with tirzepatide at ASD meeting in Vienna. The SURPASS CV outcomes trial is to be presented there. And we have a number of promising molecules. The important thing is that, they have looked at people who were on behavior therapy versus those who were on, the general recommendations for diet and lifestyle. And there was no difference because the molecules are quite potent. Drawback is that if you are not exercising during weight loss, you are more likely to lose lean mass, you lose muscle, and if you lose muscle, your bone health also gets compromised. Another important thing to keep in mind is once you stop these medications, you are likely to regain weight. Once you regain weight, you don't gain back muscle. You gain only fat.
Right.
And if you do two or three cycles of weight loss and weight regain, your body actually becomes a bag of fat with much less muscle. And I, I'll tell you one more thing. We commonly look at renal function and we don't bother if the creatinine is in normal range. Now I am seeing a lot of patients whose creatinine levels are in the range of 0.5, which shows that they already have muscle loss. Ultimately creatinine is coming from muscle mass. So these things are very important. One needs to monitor muscle mass during the journey of weight loss. We keep monitoring, periodic screening for the body composition. These things are important. And one has to keep in mind that it's a long-term journey. It is not a short-term journey. It has to be a lifelong,
So
therapy as of now.
whatever molecules you're using, the bottom line is please exercise so that you don't lose your muscle
You
mass.
have to exercise, you have to be on good protein
Good, good.
diet, you have to be, and monitoring the outcomes. That
I
is
think that is
important.
the
Rucha, what is your comment on this?
yeah,
No, so
that's the
absolutely. Yeah. So absolutely, we are all targeting behavior change, and that is very important. Do these molecules induce a behavior change by working at the level of the brain was the question. And as Dr. Makkar has extensively answered, that the answer is only while you are on the molecules. Yes.
Yeah.
In a way, it's good that once you stop the molecules, that effect goes away because we don't want any untoward side effects lingering around longer as well, right? So I would say that that's not a non-beneficial effect because you don't want any side effects of any medications that we may find out later. So in
Right.
that sense, we are hoping that when you start eating less and it translates into a behavior change, so they still need to learn lifestyle changes. It is not the end all. So yeah, I agree with Dr.
But
Makkar completely.
both these studies with semaglutide as well as tirzepatide showed that once you stop the therapy,
Yep.
the weight gains comes back.
yeah.
And within 1 year,
Yes.
people had gained 10 to 11% weight.
They gain even more. Yes, you'll
Yeah.
rebound back. Yeah.
So, it is
Stopping the
always
molecule
challenging.
is data.
Yes. Yes. Mm-hmm.
So, any questions from the audience? We have something on the chat box, Yogesh. Can you pull it up? If there's anything on the chat box. Thank you. It was interesting learning from all the experts. The biggest question is how long, how far, and how. So
It's an
how long and
exciting
how far?
journey.
It's a
It's
very
an
question.
exciting journey, and we are
Exactly.
all kind of,
Looking
excited to use.
at the number of molecules coming in and
Yeah.
looking at all of this, and then 30% waist loss, 40% waist loss. I think some of the things are very exciting.
So, the interesting thing is, I didn't go through the details of the inherent gene. If you have, the silencing messenger RNA coded for that gene now, and if you inject that, the mouse retains the lean mass straight away.
That's like I think that's like something called
There is no loss of lean mass. But mouse loses all fat, becomes a normal lean mouse.
perfect. I think
So
that's the
that
best
kind
you
of
can
things
have.
are also being worked out. But whenever we have played with genes, we have already always
Yeah, we burn our
ended up with
hands.
blunders.
When you manipulate too much with whatever is there, I know
Yeah.
it can manipulate other things and cause other
Yes.
problems.
So
And
it
thank
is
you.
too early. It is too early. Let's see.
Well, let's say, I think exciting
Yes.
times ahead. Thank you, Dr. Rucha, Dr. Makkar, Dr. Neeta, who's not here, for sharing your insight on all
Thank
of
you so
the
much.
aspects.
Yes.
Thank you
Dr.
very
Bansi,
much.
for any final comments, if Bansi is there.
And Bansi, but the final comments are this: you're wonderful. You share every data possible, and what is future? It's all for people
Can
to.
you listen me?
Yeah, Dr.
Yes.
Bansi. Go on.
Yes, yes. So first of all, thanks to Dr. Makkar and Dr. Rucha. Today we designed the program in such a way that today we will be discussing more of obesity. Otherwise, also this year American Diabetic Association, I can say that it was revolving around obesity management.
Yes.
It was revolving around GLP-1, the newer therapies, and many papers were there. And now we are looking for not just single or dual, rather triple or quadruple agonist also. Not only for weight loss management, but also there were some papers which are talking about that can we give a medication which can increase even muscle mass also. So very rightly said by Dr. Makkar that the muscle loss or a sarcopenia is a challenge and a very big challenge because people are not recognizing it. I am thanking both the speakers for wonderful program and thank you Sanjay for moderating it very nicely. I'm thanking American Diabetic Association also for getting us so much science, new science. I think every year, I remember me as Makkar Sahab since last so many years, we don't leave the venue, not for few minutes, not for few hours, constantly morning to late in evening. We constantly keep on listening new and new things. So a lot of scientific breakthrough, or you can say cutting edge science which we can listen, but at the same time, it's not possible for every physician to go and listen it from American Diabetic Association, and that's the reason we decided immediately after the conference that few topics which were very, very interesting, few symposia, if we can invite some of those who are there and they were listening directly, if they can talk on those topics, it will be very useful for many physicians. We are getting roughly 2,000 plus doctors who are getting registered for this program every day and roughly around 1,000 doctors listening also. So it's a good Diabetes India activity. I am thanking today CIPLA who had supported today activity and thanking RX Event, our event organizer, event partner with Diabetes India. And thank you everyone in Dr. S.R. Arvind, President, Dr. Sanjay is a Treasurer, and Dr. Amit Gupta who is a Joint Secretary, and to everyone who is involved with Diabetes India. And thank you very much. And tomorrow again, we will be meeting same time for the ADA session, the snapshots of American Diabetes Association. Thank you.
Great. Thank you so much.
Thank
Thank
you.
you. Good night, everyone, and see you all soon. Thank you.
Bye. Good night.
Thank you,
Bye.
Dr. Rich. Thank you, Rumrucha. Interesting.
Bye, Sanjay.